Good morning, everyone. Next topic is glaucoma intervention techniques. And we have four topics: selective laser trabeculoplasty, minimally invasive glaucoma surgery, trabeculectomy, and phacoemulsification in lens-induced glaucomas. First of all, I would like to welcome our guest speaker, Ganesh sir. He is the head of glaucoma services at Arvind Eye Hospital, Coimbatore. He'll be speaking to us on mix. And thank you, sir, for coming here and sharing your valuable knowledge with us. Next, I would like to invite Smita madam. She is the professor at Trishur Government Ophthalmic Hospital. Madam will be speaking to us about trabeculectomy. I also invite Rani madam, Rani Balamurali madam, who is the phacosurgeon at Amardeep Eye Hospital, Kollam. She'll be speaking to us on phacoemulsification in lens-induced glaucomas. First, we'll start the session with selective laser trabeculoplasty. Thank you.
Dr. Veena, who is the chairperson of this IC, Dr. Veena Vishwam, will be speaking on selective laser trabeculoplasty and her experience regarding this. Dr. Veena is a consultant at Amardeep Eye Care, Trivandrum.
Thank you, madam. So, it's not working. Hello. As we all know, we are familiar with glaucoma treatment medically, mainly medical and surgical treatment of glaucoma. We know that medical treatment has its own problems, like we need a long-term follow-up of the patient, we need long-term medications, side effects may be there, like very common in prostaglandins and alpha agonists, as well as we may require 2 or 3 medications in refractory glaucomas. Many histopathological studies have confirmed that all anti-glaucoma medications available have problems in the conjunctiva, especially the epithelial cells, the goblet cells and fibroblasts. Even beta blockers, alpha agonists, prostaglandins and combination medications have shown to have problems in the conjunctiva in the long run. So also in surgical treatment, complications are very common, failure rates are very common. Now, a newer modality which is gaining popularity is selective laser trabeculoplasty. We know that this procedure is coming recently and gaining popularity. The mechanism is not completely understood. Still, we know from the studies that SLT leads to an increased aqueous outflow through the trabecular meshwork. But whether it's due to a mechanical damage due to remodeling of the extracellular matrix due to cytokinin release or stimulation of trabecular cell proliferation is yet to be confirmed. So, multifactorial factors are the cause for decreasing IOP in SLT according to many studies. Still, it improves the trabecular meshwork drainage, selective absorption of energy by pigmented cells of trabecular meshwork, and melanocytes are the mechanism understood. It causes less collateral damage, and repeatability is another advantage of the procedure. We need a very good gonioscopy. The angles should be wide open because the spot size we use are large, and indications are primary open angle glaucoma and ocular hypertension. This was first introduced in the United States in 2001, and frequency doubled Q-switched Nd:YAG laser is used. It is a selective photothermolysis which is non-destructive, whereas in ALT it contracts the trabecular meshwork tissue. So in SLT, we said we use 532 nanometer Nd:Arg laser, 400 micron spot size. When you compare it in the picture, you can see that when you compare it with the argon laser spots, the spot size is much bigger. It is not a well focused, well defined laser spot, but the margins can be made clear. And the pulse duration is 3 nanoseconds, and energy used is 0.6 to 1.2 millijoules, average of 0.88 millijoules. So what is the endpoint when you do the laser? Clear cut endpoint cannot be like a focused laser with a clear cut burn cannot be made out, but champagne bubbles, when you give the laser, champagne bubbling is the point where you keep it as an endpoint and you decrease the power a little bit, and that is how you determine the endpoint. The lowest power when cavitation bubbles are visible is taken as the endpoint. So what lens you use to focus the laser on the trabecular meshwork? Retina lens is used. According to our experience, we use the Apasami Nd:Arg laser, but other lasers like Visulas green and LSL green lasers are also explained in the internet. So a flash pumped Nd:Arg laser, the main mechanism is photo disruption in Nd:Arg lasers, but we use double frequency Nd:Arg laser with 3 nanoseconds pulses, and the energy delivery in these cases may be plus or minus 20% of expected. But diode pumped ND VY04 is also explained. I think Ganesh sir will be able to tell us more about these laser machines. So coming to the advantages, the SLT is less costly than the current medical treatment, and treatment without relying on patient compliance is another advantage. It increases the success rate of future filtration surgeries and decreases the local and systemic side effects. And many studies have confirmed that the best results is in treatment naive patients. We have to stop all medications before the procedure, and mostly no medications are given by many ophthalmologists post treatment. But in our experience, we give NSAIDs for a week after the procedure. Usually, fluctuations will be noted in the intraocular pressure in the first 2 to 3 months. So you cannot judge whether the pressure has come down in the first 2 to 3 months because fluctuations may be noted. But very high rise of IOP is not usually seen in our experience. Delayed response of pressure decrease is noted after around 4 months. So after 4 months, we repeat the case if the pressure has not come down much. So many comparative studies between SLT and ALT have shown similar outcomes. Around the percentage reduction of IOP is similar in both SLT and ALT in many studies. We also know that in light trial, 69.8% patients remained at less than the target IOP without the need for medical or surgical treatment, and less disease progression was also noted. Trabeculectomy was required in 32 eyes in DROPS arm compared to only 13 eyes in SLT arm, and no serious laser-related adverse effects were noted. NICE guidelines also advocate the use of SLT as first-line treatment with 360 degrees of SLT coverage, and it also says that it is safe and cost-effective. These are some of the studies which advocate the use of SLT as a first-line treatment. So some disadvantages are that trabecular meshwork pigmentation is variable. Even in the same patient, inside the angle, trabecular meshwork pigmentation may be different in different parts, as well as between patients also the pigmentation may be different. So the optimal treatment parameters would likely to be to vary among patients, and Another problem is there is only very less data available. So whether this is in the long run only we'll understand whether the treatment is prompt. So disadvantages we may have to repeat the treatment, and whether it is completely non-destructive is yet to be understood. So in our experience, since the last 1 year we have been using SLT in our patients, and definitely in the follow-up of 6 months the pressure has come down in the limited number of patients in whom we have done. 20 to 30% reduction is what we have seen in our patients. We could discontinue one drug in these patients. First 6 months are not very conclusive because fluctuations are noted. After 4 months is what we have seen that the pressure is coming down. So I would like to invite our next speakers to share their experience, especially Ganesh Raman sir is an expert in the field of SLT. He'll be able to share his knowledge. Thank you.
Thank you, Dr. Veena. That was a good baseline about SLT. As we all know, SLT is a big game changer. It's a big disruptor in the management of glaucoma. Definitely, the light study was the one which brought about this disruption. So, putting the patients on drugs and then going with the adverse effects of drugs is very difficult. So, SLT has really brought about such difference. Many people initially were skeptical about the utility of SLT, especially in the Indian eyes. So, sir, would you please share your experience regarding the machine used and the experience regarding intraocular pressure control duration and the adverse effects?
So if you see the publications from India, you have two publications mainly. One is on juvenile glaucomas from the AIMS group, and then you have one publication which has a, I think 45 to 50 eyes followed up for 5 years, but they have done it in angle closure eyes post-PI in PGI Chandigarh. So that's the only two publications. But we have been having SLT machines since 2009 on and off. So we've been doing, initially it was a demo, and then after that we tried to have the machine. From 2011 till 2018 we were having the machine, and we did a good number of eyes. And treatment naive eyes, as you mentioned, they work very well. Now we have the newer machine. 2018 till 2022, 2023 we didn't have a machine. The previous machine was defunct. So now we are using the neodymium orthovanadate laser, that is the Zeiss one, green Visuda. So we have a series of patients, about 89 for the project, and almost 67 of the patients are off medication for the last 1 year. So that's really quite commendable. And we have them followed up with visual field also. The 6-month interim analysis is pending peer review process in IGO. So hopefully by March we should have it out, and then we should subsequently have the 12-year data also out of these patients. So in that sense, it's really very helpful to reduce the burden of medication for the patients. And all these patients have a visual field also. So, I mean, just talking about the pressure, sometimes people are not convinced, especially with the light trial being there, which is for 6 years. We always try to get the visual field of all these patients. And we see that 47 of those patients who did for the interim analysis out of the, I think 57 eyes, 59 eyes, they have not progressed. So we are very happy with that results.
What was the initial range of IOP of these
patients?
So
the pre-operative IOP was about 19.58, something like that. And then the post-operative, at the end of 6 months, the average was about 18 point. We just had a 1 millimeter drop in mercury. Millimeters mercury, but the advantage was that that was without medication. So what we are trying to emphasize, it can add as a substitute for medication. We are not, because those patients were actually quite satisfactorily controlled, but we were able to substitute SLT for medication.
So pre-operatively, these patients were on anti-glaucoma medications, and their IOP was at 19. And so you gave SLT, and now their IOP is at 18 without anti-glaucoma medication. That's remarkable.
So the baseline is over a period of time, because we have been following those patients. When you look at the baseline was 24. Average was 24. So you were able to bring around 5.5 millimeters of mercury drop from baseline. But the baseline is not, we're not able to give them a washout. So we took the baseline as the first recorded IOP with which they came. They could have come maybe 8 years before, 6 years before, 10 years before also. But we went to the records and took that as the baseline.
Post SLT regimen? Like, do you give steroids or do you give NST?
No, we stop all medications, including anti-glaucoma medications.
No, about this
No,
salt
we don't
trial.
give anything.
You don't give anything?
We check the pressure 1 hour later and we let the patient go free.
Nothing.
Nothing.
Oh.
So why is that? Is it to avoid steroid-induced glaucoma? Or,
That is one reason. All these medications which you see, they have BAK. Even the lubricants will have BAK. Steroids have BAK. The BAK has a propensity to cause release of prostaglandins by itself. That's been known already. And when that happens, you increase the uveoscleral pathway outflow. Now these are mechanics, and even the MIGs which we're going to talk about are mechanisms which work on the pressure dependent pathway. That means the uveoscleral pathway should not function much more than the conventional pathway. So as the intraocular pressure rises, then only these devices work. These mechanisms work. So you have to not use any medication which increases the uveoscleral pathway outflow. So SLT will not work if the patient is on, let's say, a bimetoprost or travoprost. We are very particular that we switch it off about 6 weeks, give a washout, change them to a latanoprost if necessary, and then do the SLT. So all these nuances and tricks are very, very important if you were to plan SLT.
That's a very important tip, sir, that SLT will not work if you're on a bimetoprost or travoprost. Have you performed repeat SLT on these patients?
So of the interim analysis, the 57 patients or so, we have 3 patients who needed a repeat, but we did the repeat after 4 months.
So how, like 180 degrees, 50 spots?
All the patients underwent, whether it's a repeat or a primary, they underwent 360-degree SLT.
360 degrees, okay.
Is there any gonioscopically different appearance pre and post
No,
SLT?
you don't find any difference. Unless you have the record, you won't be able to make out. If it's been done very aggressively, for example, if you use very high pressure, high laser energy, then you will have those spikes of, the sawtooth sign PAS will form even with SLT. If novice has done with, and they have used a higher energy level, you will find, but if it's done with the optimum energy level, which is recommended by the company, then you don't find those, you don't find any sign at all.
So, actually, this should be, in your experience, SLT should be an important treatment.
Absolutely, we advise about 50 patients SLT every month for the patients who walk in. Either they are on medication or they're treatment naive patients. The acceptance is little poor because we are not able to follow it up, mainly because our counselors are busy and they have to counsel so many other things. But we have a new facility, so in that we are going to, more. So we are collecting the data and see how the acceptance is. But it surely should improve over a period of time. The issue is testing the patient and then doing SLT. Once you dilate the pupil and then do a fundus photo, that day you cannot do the SLT. So the patient has to come back again, and they feel that as a frustration. So if it's like a YAG-PI, then it's very easy. So what we do is we investigate the patient one day before or the visit, and then the next day we would like to capture the visual field, do the visual field and do the SLT and send them.
Is there any difficulty in convincing them that you're going to use laser as a treatment modality?
And definitely. They feel that when they talk about laser, they think the refractive error will be sort of done over with. They think it's similar, but we have to especially tell them that no, this is for your medication related issues, because you're using medication, we have a substitute for that. After that, they feel convinced. That's not an issue.
This is for those who have not seen the procedure much. This is a simple procedure, doesn't require much of expertise or anything. It is even easier than PI, I think, because the beam is not very tough to focus. It's a diffuse beam, and you can just, the champagne bubble appearance is the end point, and it's easy actually. We give 180 degrees, usually we treat 180 degrees of the angle first, 50 spots are given, and then the patient is followed up, and after 1 month or so we can give the other area also. But as sir said, and in many studies it shows that after 4 months only the IOP reduction starts coming in. So you need to be patient after 1 year. So you need to be patient. But definitely a useful tool to be used in glaucoma patients.
Nine patients have got done on the same day, and that's been published.
Same day, sir. Okay. This, okay. 360. Okay, thank you. Now I invite. Okay. So now I invite our guest speaker, Ganesh V. Raman sir, to speak on minimally invasive glaucoma surgery.
Thank you, Dr. Veena, for this opportunity, and thank you, KSOS, for having me here. So, if you minimally invasive glaucoma surgery is many people talk about robotics, and robotics. In fact, we have been into robotics for many years, even before robotics actually came up. So, all the SLT we are talking about is actually robotics, and the robotics which we use is actually, in micrometer scale, whereas robotics, when they talk about in general surgery and other branches, is actually millimeter scale. So we are already into robotics for many, many years, especially when you're doing PRP or let's say YAG-PI or any laser procedure. So the advantage why we are talking about SLT so much is if you can manage your failures with SLT, it's very easy to manage your failures with mix. You cannot approach mix without understanding SLT. So it's very, very important that you know that SLT is very important, and at the same time, the corollary is the same. So if you have issues with mix, that means you can overcome that easily because we've been doing SLT for many years. Because you're addressing the same structure, you're addressing the trabecular meshwork in a different way. Here you are going physically and altering it, whereas in SLT you're just doing a laser. So SLT and mix are actually, the aim is the same. The aim is to reduce the burden of medication for the glaucoma patient. One is through laser, which is very, very less expensive. Other is through mix, which is quite expensive, carries the risk of endophthalmitis also, which you don't have in SLT. So if you can learn SLT, it's really very good. The mix and SLT, invariably, they address only primary open angle glaucoma. So I would suggest that if you want to burn your fingers, burn it with SLT first rather than burning it with mix directly. So having said that, so these are all the mix which we have. To your left, you'll have a lot of devices. And to the right is the traditional glaucoma surgery. So in the left, you have non-bleb forming procedures like endoscopic cyclophotocoagulation, which address the ciliary processes. And then you have the outflow channels, implants like the iStent or the Hydrus, or you can excise or cleave the trabecular meshwork to enhance outflow, or you can dilate it using the Omni devices, which are not available in India. So we'll mainly talk about the excision and cleaving of the trabecular meshwork. And the logic, as talked about SLT as well as mix, is to use the natural outflow pathway of the aqueous production and drainage. So which have been so far and been untapped surgically, and it's more physiological. So here, so the natural outflow pathway is actually a pressure-dependent pathway. It's not the UV scleral pathway. UV scleral pathway works better in some other animals, but in humans, the natural pathway is the trabecular meshwork, and that by genetics or epigenetics stops functioning at a particular point in time of the patient. So if we can catch the patient early, you can do a SLT, for example, and the logic of SLT is the mechanism is not exactly understood, but the one aspect says that you have stem cells in the non-pigmented part of trabecular meshwork. So since you have a larger spot size of 400 microns, those stem cells start changing and then start populating the pigmented trabecular meshwork also, and they enhance percolation. So that's another rationale which people are thinking about. Why they say that is because the corneal endothelial cells in the periphery of the cornea also starts increasing. So the cellular migration happens anteriorly towards the cornea and posteriorly towards the pigmented trabecular meshwork. So that's another thought which people are thinking about. So this is more physiological mix as well as SLT. So you have certain proprietary devices. So you have the iStent by Glaucos, Hydrus by Alcon. No financial interest in any of these companies. And then for excision, you have the Kahoot dual blade. Trabectome was a device which was being sold in India, but now it's been taken off. And then you have the Tenitos hook. So the I-axis by Glaucos, which is not available here, can be reused, and the Tenitos hook can also be reused. The Trab 360 or the Omni 360, these are the same devices but used for different purposes. So one is you can tear it, or you can viscodilate the Schlemm scanner. And then you have the Mix Plus device, that is that touch the conjunctiva. So we have our own alternative, which is the canaloplasty. Maybe we come to that later. And if you excise the conjunctiva, the pressure flow from Santen is another device. So these are all tubes which are put in the subconjunctival space. So since you don't have that, you have the generic equivalent in India. So for the excision, we use the needle, which is the bang. And if you want to do the tearing part, instead of using the catheter, you can use the GAT procedure. And for mix plus, since you don't have a small device, you use the ab external cannuloplasty. So for the GAT, you can either use the catheter or the suture. Catheter is being developed by the LV Prasad and the Orolab group. And again, for ab external, you can use the suture or the catheter. So you could call them the equivalent generic devices. And for the reasons of economy, we use these along with the stenting devices, which we don't have any alternative to. So these are the photographs of all the devices. You can see this is the first generation iStent, and then second generation, and this is the hydrous implant, and then you have the ECP device, and then the trabectome, and then Omni devices, and then the KDB dual blade. So the main indications are for mild to moderate open angle glaucoma. So it could be primary or secondary, and patients on 2 or more glaucoma medication. The logic is not to bring the intraocular pressure to very low episcleral venous pressures, but to reduce the burden of the medication to the patient. And it can be combined with cataract surgery, can be done individually also. And if the patient is not tolerant to glaucoma medication, or he has some barriers to usage of glaucoma medication, that's another indications. So the main advantage is it's minimal trauma to the conjunctiva. It spares the sclera also, because you don't touch the sclera. And that's a very important structure when you want to do a conventional glaucoma surgery. It's an ab internal device, almost all of them are ab internal, and it's a bleb independent procedure. So you don't form a bleb, so risk of mitomycin C related issues. It's a totally physiological procedure. You have very reduced surgical time. You can always combine it with cataract surgery, and you have very rapid visual recovery with lesser post-operative visits. Very good safety profile. Cosmetically very acceptable. So after MIGS, you could always give a contact lens to your patient, if they want to wear it. When was the last time after glaucoma surgery you gave a contact lens to your patient? I don't think anybody can remember giving a contact lens to a patient. And the most important thing is intraoperative gonioscopy. So for that, you have to be familiar with the gonio lenses. So there are numerous gonio lenses. The Vogue was the one which came out with surgical gonio lenses initially, that what we're familiar with. But outside, you used to get the Ocular Hill gonio lens and then Swan Jacob also. So the Ocular company sells both the Hill gonio lens and the Swan Jacob. You could get any of them. They cost about 50,000 rupees each, and it takes about a month for you to procure it. We have the Ocular Hill, and that you see on the left hand side here, and that's the Ocular Hill gonio lens. And here, this is on your right hand side is the S Prism gonio lens. That's by the Glaucoma company. So if you buy a set of eye stents, they'll give you this lens for free. Otherwise, its cost is about 7,500 rupees. You have non-handled, that is a self-retaining gonio lenses. So one is by Ocular, that is known as Secure Flex. Other one is by Catina, that is also known as Coriza lens. So these are some lenses which you can procure. Any company which sells these products, they can help you with the gonio lenses. For the GAT procedure, you need Prolene sutures. So we have the 50 and the 60 Prolene suture. Orolab used to make them and give it to us separately, but now we get the sutures from the regular supplier, which could be Orolab, but we make the suture ourselves. So blunt the tip ourselves using a thermal cautery. So we do that in the OR. Orolabs have stopped selling it, mainly because now they have to go through the DGCI to get a license to market it. Angle anatomy is very, very important. I showed this slide yesterday also. So normal angle anatomy is what we target for our primary open angle glaucoma patients for SLT as well as for MIGS. So you should see a sliver of ciliary body band for all your patients. So if you don't see the ciliary body band, that means the iris is anteriorly inserted, it's abnormal iris. Your MIGS or your SLT will not work so satisfactorily. You may get a paradoxical raised IOP after you touch those angles. So you have to be very, very careful. The featureless angle which is shown here, this is the most risky. The anatomy is, we have operated some of them, we have never been able to cannulate those angles. So the suture doesn't go into it at all. You keep incising, cutting, the suture will never thread. We really don't know what exactly is wrong. We are going to get an ASOCT, then maybe we'll start looking into these eyes. The third one is the high iris insertion. So this is again easy, manageable. easily manageable, mainly because if you decompress the globe, you will find blood in the Schramm's canal. So you can see where the trabecular meshwork is. And prominent iris processes are again easily identifiable. The trabecular meshwork behind that is easily identifiable. So these can be easily tackled. The most difficult ones are the featureless angles. So I would strongly recommend not to do SLT in these eyes or mix in these eyes. So stenting the canal was the first prototype device which was launched way back almost 2007, and this is the second generation, and you can see that the device is like a collar stud. So it has a flange and then a thorax and a head. So this is the flange at the bottom, and then you have the thorax and the head, and the central lumen which percolates here is about 80 microns, and the side lumens are about 50 microns. So the logic is that you insert it into the trabecular meshwork and it allows aqueous humor percolation into the Schramm's canal. So this is how the photograph looks like if you have inserted it, and then you can see blood coming out of the stents, and then you tap it. It comes preloaded in so once you decompress, you can see the blood in the Schramm's canal. So that's a very good indication that you have selected a very nice case. You can see the sliver of ciliary body band. You see a nice trabecular meshwork which is filled with blood. The Schramm's canal is filled with blood. That's 3, and then you can see the slight, shawl base line at the top. So it comes preloaded, and then you shoot 2 devices, one after the other. So it requires a little bit of learning curve, but otherwise it's very easily performed. And then you turn around. The idea is to insert the inferior one first, and then do the superior one. So if you do the superior and the blood regurgitates and then it blocks the view, then you won't be able to do the inferior again. So do the inferior one first, so that the blood goes down because of gravity, and then you can shoot the second one. It is quite costly, so we offer it to patients with mild to moderate open angle glaucoma who have insurance, and that's the end of the procedure. Coming to excisional goniotomy, the traditional versus excisional is you have the needle-based device or the MVR-based device, but you have the Kahook dual blade now. So these are quite sophisticated devices. It has it has a ramp and then 2 blades at the side. So as you introduce the ramp into the trabecular meshwork, the knives which are at the edge cut the trabecular meshwork, and the strip of tissue is peeled off. Very sophisticated, very good results. We are very happy with it. And this is how it works. So you can see when we have a small nodule there, iris trabecular meshwork nodule. So we can do this on either side of the nodule. I think okay, we'll just let it play. It's blocked. Slow. Stop हो रहा है. Stop कर दे. Yeah, after that. After that. After that. Next. Yeah, that one. Just to the middle. Yeah. It stops, huh? It's slower. Okay, so we'll play it from the beginning. So you can take the blade and cut on either side. I'll come to the next one, which is the Tanitos microhook. Like I mentioned, this is reusable, and the logic is same as the dual blade. You can incise 120 degrees of the trabeculomesh on the nasal part. You have 3 instruments. One is a straight, and 2 are angled. So the angled one are for the approach from the supranasal aspect into the temporal region. So there you can incise 120 degrees. So if you are not happy with, let's say, 120 degree incision, you can always do one more 120. So for people who are not able to do a complete GAT, this is very useful. So you have a 240 degree excision compared to a just 120 degree excision. So the logic here is that everybody knows that the nasal area is filled with collector channels, but the ones on the temporal side can also be recruited for functionality. If you excise the ones on the nasal temporal side, they also start functioning. When you do for a diseased eye, you find more vessels on the nasal side. That doesn't mean the temporal side is not present. It will be present, it just starts shutting down. So you do that, and that's why many people say GAT works better than bang. So this is another video where video of my friend, Dr. Devendra is, so after the phaco is over, this is the infratemporal angle which is approaching. You can see the ciliary body band and then the scleral spur, and then you just incise just like a hook dual blade. So this is again a reusable device. It comes in 3 pairs. I think the APAO meeting in Delhi, they are going to launch this. The company is going to launch it in India. Then you can purchase it. As of now, we got it complimentary of the manufacturer. Some of us have got it, and we used to purchase it from outside. So this is the left being done, and then you can do the right similarly. The supranasal, infratemporal angle, supranasal approach. So you have to sit on the opposite side of the patient and then do the procedure. Bent ab interno goniectomy is another simple device. This is very commonly done, very less expensive, and you just bent the 26 gauge needle or 24 gauge needle and then strip the nasal part of the trabecular meshwork. Gonioscopy assisted transluminal trabeculotomy was addressing 360 degree of the problem, and you thread a suture into the Schlemm's canal. It could be a 5-0 or a 6-0. Because the anatomy is so distorted, we always keep both the sutures together. Patients who have been chronically medicated, we use a smaller bore suture, which is a 6-0. Patients who have recently been diagnosed, their Schlemm's canal is not so small, so they can accommodate a larger suture, that is a 5-0. So we keep both the sutures ready, and then wherever is necessary, we use that. Sometimes 5-0 suture doesn't go in. We use it with a 6-0 suture. And once the suture is seen on the opposite side, you catch hold of it, and then you bring it out and tear the you can see the suture in the Schlemm's canal. Bring it out and then do a trabeculotomy. So the whole suture gets, you remove the gonial lens and then you grasp hold of it and then you tear the trabecular meshwork. So this is the eyes, the left eye on the left side is done 1 year back, and this is done recently. And you can see that we always leave 40% fill. If you have done extensive cutting over the trabecular meshwork, you always leave 40% fill of oro gel, which is sodium hyaluronate in the antechamber. But if you have done limited goniotomy or limited excision, we don't need to do that. So the merits of mix are numerous. You have better quality of life, spares the conjunctiva, it's very cost effective. And the demerits are you could have only a modest ability to reduce the intraocular pressure. It doesn't achieve low IOP and cannot be modified unlike TRAB. So you cannot do a suture removal or bleb needling or anything. So if it's done, it's done. You have to go to plan B for that. So say case selection is very important. So mild to moderate glaucoma is the ones which we usually do mix for. And if you have to combine it with cataract surgery, make sure you do a uneven full cataract surgery in these eyes. So don't touch the iris too much, avoid pigment dispersion, and deepen the chamber with sodium hyaluronate. And extensive mix, always like GAT, always leave sodium hyaluronate, which is 40% fill. And limited mix like KDB Bang, Tanitos, don't leave any OVD in the chamber. Be careful of patients who have limited hypertension control or or anticoagulants, or they have fluctuating BP. So this is very important which you have, because they have a tendency to bleed later on. So I'll stop here for want of time. Any questions, happy to take. Thank you.
So, what is your experience regarding the hyphema which develops after GAT procedures?
So the GAT procedures, we always leave 40 to 50% fill of sodium hydrate. When you do that, you don't get hyphema.
And what about the delayed hyphema? Have you seen
Delayed
cases
hyphema? We
of
have had
delayed
patients.
hyphema?
Yeah, we have had patients with pseudoexfoliation syndrome and patients on anticoagulants. They are the two patients who develops delayed hyphema. They can happen about 3 months later also. So for them, we ask them to just take rest with the head end elevated, and then it resolves on its own. There's no active intervention that we have to do, but we ask them to take rest for a day or two. It can quite sudden, it can happen. In that, supposing they were driving or something like that, they can be really debilitated because of that. That's something which we have to think of. So hypertensives, we're very particular that either they're on chronic medication and have a very good control, or we have a plan B for those patients, we do a canaloplasty.
You have a very good experience regarding canaloplasty.
Yeah.
I would have loved to ask you some questions about it, but I don't think we have enough time for
Yeah,
that.
maybe we'll discuss later.
Sir, acute postoperative IOP rise after the sodium alginate and hyphema will be there if.
Yeah, if you believe more, like there's a little calculation which we have to do. In fact, you could also get a on-table tonometer, which is used by LASIK people for checking the intraocular pressure. So you have those tonometers, which are Baraka tonometers. They are based on the Glaucoma model, and they are fixed area tonometers with variable force. So since you have them, you can leave the pressure at 30 millimeters of mercury. Okay, they don't cause any problem. But when you do overfill, that day, same day, evening, patient will have raised IOP. So we can burp the wound on the slit lamp. That we have done. If necessary, we do that. So we put a drop of povidone iodine, and then you have incision through that, take a needle and burp the wound. Immediately they have a relief. So that is how we manage. But now we are trying to, mix oro gel with irrigating solution and leave about 40% fill. Thank you.
Thank you, sir. Okay. Now I invite Smita Narayanan madam to speak on trabeculectomy.
Good morning, ladies and gentlemen. So today I shall be giving you my take on the procedure of trabeculectomy and how to optimize it. So till about 25 to 35 years back, we had only two surgical options for glaucoma. And that was one, which is the gold standard filtering surgery, that is the filtering surgery of trabeculectomy, and the cyclodestructive procedures. I'm meaning about here in this part of the world, and then the cyclodestructive surgeries. But now we have a large repertoire of surgeries, including, as sir described about in great detail about MIGS, and cataract surgery is again a type of MIGS, and also the glaucoma drainage devices. So today I shall be speaking on how I use trabeculectomy, or how I perform trabeculectomy. So before we actually discuss about it, let us know about the anatomy of the angle of anterior chamber, especially the gonioscopic view. So you can see this is the gonioscopic diagrammatic view of the gonioscopic appearance of angle of anterior chamber. And the juxtacanalicular layer of trabecular meshwork provides the greatest resistance to the aqueous outflow. So you can see these electron microscopic pictures here. The first picture, this one, this is the picture which shows the normal trabecular meshwork under the electron microscope. The second picture shows how it appears in an acute attack of angle closure glaucoma, and the third one is in a chronic case of angle closure glaucoma, and finally how the primary open angle glaucoma trabecular meshwork appears. So you can understand the great deal of damage and edema and the resistance which happens to the outflow of aqueous. So the trabeculectomy surgery is that filtration surgery which bypasses this diseased or damaged trabecular meshwork such that the aqueous is able to go from the anterior chamber to the subconjunctival space where it forms a filtering bleb. So before actually we perform the trabeculectomy, we must also be familiar with the anatomy of the limbus, the surgical anatomy. So if we were to dissect a rectangular flap from the sclera to the clear cornea, we will encounter three zones. So one is the white zone of the sclera, then is a blue-gray zone containing most of the drainage parts of the angle of anterior chamber, and then there is the clear cornea. So this junction between the white and the gray area is the posterior limbus, and immediately anterior to it lies the Schlemm's canal. So when we are doing the sclerostomy punctures during the procedure of trabeculectomy, we should never cross this junction of the posterior limbus. Immediately posterior to that lies the scleral spur. The anterior limbus is 0.5 millimeters anterior to the insertion of conjunctiva. Again, before performing any surgery, pre-op evaluation is a must. If a patient is on anticoagulants, it is best to stop the anticoagulants for about 3 to 5 days, because the blood in the surgical site is the nemesis of trabeculectomy, because it brings forth fibroblasts and that cause conjunctival or subscleral fibrosis, and that prevents the blood from functioning. Giving 2 to 3 grams per kilogram body weight of mannitol, which should be given within 20 to 30 minutes, is a good procedure to bring the intraocular pressure down. Otherwise, there are, especially in cases of acute attacks of angle closure glaucoma, where the intraocular pressure is not controlled because the patient came after quite some time, quite late, then in those patients, somehow there is a sudden shallowing of anterior chamber and there would be difficulties in performing the surgery. Look at the patient so that you can understand how the prostaglandin associated periorbitopathy causes a very deep superior sulcus, and therefore you can anticipate the difficulty in performing the surgery. Give an anti-glaucoma medication drug holiday by prescribing the patient tab Diamox, that is the acetazolamide, for about 10 days or 2 weeks prior to surgery. And you can also use topical steroid drops, FML drops or prednisolone acetate drops, but remember, keeping in mind that these steroids themselves can cause a steroid-induced glaucoma. Then choose the surgical site, and that is best. Though trabeculectomy is best done at the superior position, which is slightly staggered superior nasally or superior temporally, this allows the aqueous to flow down equally in both directions. And also, if you are to perform a trabeculectomy subsequently, this will allow you to have enough space for a second trab or placing a glaucoma drainage device. Avoid the inferior position, because that is the place where infections are more likely to occur. As I have shown in this video, check the mobility of the conjunctiva, and that can be done by using a bud dipped in proparacaine, and you should see that the conjunctiva is mobile. Conditions like previous cataract surgery or pterygium surgery, you may find that the conjunctiva is adherent, and that discovering it on the table is not a good idea. I usually prefer a subtenance anesthesia because it can be reinforced more and more. People do give peribulbar anesthesia, but with peribulbar anesthesia, you must be careful not to give adrenaline and also not to give a pressure post anesthesia. Many people prefer to do with topical anesthesia. The exposure for trabeculectomy can be best provided nowadays. I use the corneal traction suture using the 80 vicryl on a spatulated needle passed through about 90% of the depth of the cornea, because that gives you an atraumatic field. But the best option, it seems, is the Ong speculum, which prevents the movement of the eyeball and gives you a very good exposure. Previously, we used to use the superior rectus bridle suture, but again, that would bring blood to the surgical site and again would cause the trabeculectomy to fail. I prefer to give injection mitomycin C, about 0.1 milliliter of whatever concentration I have shown here, depending upon the severity of glaucoma. It is given about 8 to 10 millimeters from the limbus, avoiding the insertion of the superior rectus. Then I use a bud to spread the drug mitomycin C towards and away from the limbus and towards the sides. A peritomy can be performed using, I prefer to use a Vanna scissors and an atraumatic forceps like the Pierce-Hoskins forceps. I do not use the LIMS forceps because of its tooth nature. About 5 to 6 millimeter of the conjunctiva is cut. Avoid excessive manipulation or buttonholing, and then I close the blades of the Vanna scissors and then dissect under the incision in all the directions possible, so as to allow for the mitomycin C, to act, especially if I am using sponges. The incision of the conjunctiva can be either a fornix-based incision or a limbus-based incision. I personally prefer a fornix-based incision, though intraocular pressure control is equivalent in both these techniques. The fornix-based incision takes less time to close and is less likely to need an assistant, and it also gives us a diffuse and low bleb. Hemostasis can be performed using minimal cautery because over-enthusiastic cautery can lead to scleral shrinkage. So in all these situations where you are injecting mitomycin C or where you're giving subtenance anesthesia, a drop of brimonidine would be very useful because it will shrink the blood vessels, and you can then avoid the blood vessels and give injections, preventing the bleeding. As far as in cases where you want to apply the sponge, after making the peritomy, you can use sponges dipped in the required concentration of mitomycin C and again kept for the required duration, about 2 to 3 minutes. It is very important that the number of sponges that you put inside should be equal to the number of sponges you keep out, because you don't want to retain small fragments of sponges or the sponge itself to cause scleral melting. The sponges can also be soaked in trypan blue for easier retrieval, and since they are biohazardous waste, you should take proper precautions to dispose them. And after removing the sponges, then you have to irrigate the area with about 15 to 20 cc of balanced salt solution. The injections, I feel, provide a precise control of the dosage of drug that can be given in that area, which is not only safe and effective because it gives there is a lesser risk of losing sponges or sponge fragments, and that gives you a perfect bleb, which is avascular with numerous microcysts, and it is usually associated with good control. And besides, naturally, injections take less time. Then the step of scleral dissection. I usually make a 4 to 3 millimeter size rectangular flap. You can have a rectangular or a triangular or a trapezoid flap, that is your choice, but finally the geometry doesn't make much of a difference. The dissection should be even. The partial thickness scleral flap that is created should be, I use a crescent blade, but the important thing is that the undersurface of scleral flap should be as smooth as possible, because otherwise if it's a rough surface, it will promote fibrosis. The sides of the flap are cut 1 millimeter from the limbus according to the Moorfield safe surgery technique, so that allows for the posterior flow of the aqueous, and therefore we get a low bleb. And some of the people prefer to give an intrascleral application of mitomycin C. I used to do it, but I don't think that makes a big deal of difference. The next important step is the paracentesis. A side port blade or an MVR blade can be used to perform a paracentesis about 45 to 90 degrees from the main trabeculectomy site. This not only allows for a gradual decompression of the anterior chamber, it allows also for the various instrumentations which can be, or drugs which can be used to keep the anterior chamber maintained. And it should be created in a self-sealing fashion. Then we come to the main portion of trabeculectomy, and that is the sclerostomy. So that before that we have to enter the anterior chamber, and I usually use a keratome to enter the anterior chamber. That keratome I usually enter in the clear cornea. So that is why knowing the surgical anatomy of the limbus is very important. So once you enter the clear cornea, then you can use the Kelly sponge or the side port blade for performing the sclerostomies. And the sclerostomy should be of sufficient size, but leaving about 1 millimeter on either side of the ostium, so that the flap completely covers it. And very importantly, the anterior chamber should not shallow at any stage during the sclerostomy. Sometimes if you are anticipating that there would be a risk of any of the serious complications of trabeculectomy, it is best to put a pre-placed suture. Iridectomy is performed using the Vanna scissors and the iris forceps kept at 90 degrees to each other, and iridectomy opening should be larger than the sclerostomy opening. The flaps can be sutured by multiple ways, like the fixed sutures, releasable sutures, or adjustable sutures. I use the 10-0 nylon where the knots are buried. This is the technique of releasable sutures by Kolker's technique. And finally, the conjunctiva is closed with the same suture which was used for corneal traction, and that I use 2 wing sutures, which is vicryl, and then a central mattress suture. And I usually prefer that the conjunctiva overrides over the cornea, so that later on, even if it recedes, the wound is well covered. So I conclude by saying that trabeculectomy is just a basic step. It is the post-op control of the patient which is the most important. Thank you very much for your kind attention.
Thank you, madam, for that very informative talk. We are overshooting time, so I request next speaker, Dr. Rani Balamurali, to speak on phacoemulsification on cataracts induced glaucomas.
Good morning, all. I don't know how much time I have for this presentation. So this is treatment of surgical treatment of lens-induced glaucomas. So these are the common causes of lens-induced glaucomas, which is secondary glaucoma, where the crystalline lens contributes to the increase in IOP. There can be a neglected intumescent cataract, dislocated lens causing pupillary block, phacolytic lens material causing lens particle glaucoma, and phacoantigenic glaucoma. The mechanism of phacomorphic is a secondary angle closure one. Then clinical features are similar to angle closure glaucoma with severe pain, headache, blurred vision, and slit lamp examination will show a shallow anterior chamber, and gonioscopically the angle will be closed. You have to lower the intraocular pressure with aqueous suppressant and hyperosmotic agents. Do laser iridotomy for rapid control of IOP, and it gives you space in the anterior chamber during cataract extraction. Surgery can be done under topical, subtenons, or perimulbar block. You have to give a gentle massage if the angle is too shallow. You can give hyperosmotic agents, or both cohesive and dispersive OVDs should be used. So the studies show that pars plana vitrectomy is also helpful in getting a deeper anterior chamber as well as perimulbar block. So this is a case of phacomorphic glaucoma managed with the IV mannitol and subtenonous anesthesia. The lens is too tense, the capsule. You can make multiple punctures in the anterior capsule and let out the material inside the capsule to reduce the intracapsular tension. So you can aspirate the content as well as massage it out. Now you can easily conduct the capsulotomy rhexis without the fear of an extending or Argentinian flag sign. You can complete the phacoemulsification. As you see, the capsulotomy is very easily performed and phacoemulsification is completed. So next is a case of phacomorphic glaucoma with multiple posterior synechiae. So you have to release the synechiae with the help of visco as well as forceps. Now we have to insert a BHEX ring in this case because of the small pupil. All the flanges are inserted and you get a good hexagonal pupil. And you can complete the capsulotomy and complete the phacoemulsification. So next is a phacomorphic glaucoma where you can see the synechiae, there is a good dilated pupil, but the synechiae is in the periphery. So you can do the capsulotomy is done in the same fashion with multiple punctures and aspiration of the contents, and then you can do the peripheral phacoemulsification, but the synechiae is not released till the end of the surgery because it gives you a good support for pulling the capsule as well as during your phacoemulsification. So this is another case where you are doing a small incision cataract surgery. Here in the incision is too small, 3.5 to 4 mm incision is made. And once you finish the capsulotomy, you are delivering the lens into the sulcus, and with the help of a pre-chop, it is chopped and the pieces are delivered out with the help of a vectis. You can place a foldable IOL in this case through the small incision tunnel. So the lens particle glaucoma is caused by the grossly disrupted capsule and liberated lens fragments in the anterior chamber. It may occur after cataract surgery, trauma in yak capsulotomy. The clinical features are similar, but inflammatory component is more. You need more steroids, cycloplegics, and aqueous suppressants. Faculty glaucoma is quite common. It is because of the obstruction of trabecular meshwork with macrophages, lens material, and high molecular weight lens protein. And the clinical features are similar. You get microcystic corneal edema, deep anterior chamber, AC is open with pseudo-hypopyon. The treatment is also similar, and the definite treatment is cataract extraction. So this is a you can control the inflammation and you get a clear cornea and a white eye. Then you do the surgery. So we have planned a phacoemulsification for this patient, and once we proceed for anterior capsulotomy, you can see the zonules are 2 lakhs, and it's difficult to perform the anterior capsulotomy. So the capsule is cut with vanas, and the lens is delivered into the anterior chamber, and SAC is performed. When you deliver the lens into the anterior chamber, use 2 instruments so that the zonules are not further weakened. So convert into an SICS and deliver the lens. Since the zonule is 2 lakhs, you can see a little liquid cortex in the vitreous also. If it's a small amount of cortex, you can retain the cortex there and give more steroids. So in this case, the 3-piece lens is sutured into the eye with the 10-0 Prolene suture, and the surgery is done. So this is faculty glaucoma, which is medically managed, and we are now planning an SICS. Here also the capsule is, the zonules are 2 lakhs, and the capsulotomy is not, CCC is not done. We have done cut the anterior capsule with vanas. Now the lens is delivered with the help of 2 instruments into the anterior chamber. You can see a lot of liquefied lens material in the vitreous. So this has to be removed because it will cause a lot of inflammation postoperatively. So once you put the IUL and suture it into the iris, and then you do with the help of an anterior vitrectomy, you can make a posterior capsulotomy and remove the vitreous along with the remove the lens mat along with the vitreous cutter. So this is another case of faculty glaucoma, which is medically managed. Cortex is in the anterior chamber is aspirated. Here we could perform a CCC. A grade 4 nucleus is there, and it is prolapsed into the anterior chamber, and an IOL scaffolding is done. This will protect the zonules as well as the posterior capsule. You can do a pre-chopping in the anterior chamber and remove the fragments with the help of phaco, and the surgery is done. This is another case of faculty glaucoma, and we have now planned a small incision cataract surgery. Just like any other case, we could get a good CCC. So lens is delivered into the anterior chamber, and with the help of vectors, it is delivered out. So all these cases, there will be a lot of inflammation postoperatively. You have to manage with steroids, and the duration and frequency should be more, and you have to follow up. Most of the glaucoma will be controlled, more than 19% of the glaucoma will be controlled with the cataract surgery. But after postoperatively, you have to follow up the patient for persistence of raised intraocular pressure. Thank you.
Thank you, Rani Madam, for those practical tips and beautiful videos. I think we are coming to the end of the session. Any doubts from the audience?